This is Insight and Beyond, brought to you by Moorfields Eye Hospital Dubai, a podcast where knowledge meets curiosity. World-leading experts in eye care will dive deep into the world of vision, health, and insights in innovation. Each episode is a step into the future of healthcare and more. Tune in, get inspired, and see the world differently.
Good morning. My name is Dr. Salman Waqar. I'm a consultant here at Moorfields Eye Hospital in Dubai, specializing in glaucoma and cataracts. And a very warm welcome to our podcast, Insight and Beyond.
Good morning. My name is Dr. Miguel Morcillo. I am consultant in the Moorfields Eye Hospital Dubai. I am specialized in the cornea, cataract, and refractive surgery.
So, Miguel, it's a nice opportunity to chat about a few things.
Same.
I understand your team has had quite a lot of experience with refractive surgery. And I was wondering if you could give us a little bit of insight into what refractive surgery, or more commonly, laser vision correction, is all about. And perhaps we could explore together some of the different types. And then I could maybe pitch in with what are the kind of indications with regards to glaucoma where this might not be suitable, or what other options might be suitable instead. So over to you. A little bit of an insight into refractive surgery.
Thank you, Salman. Refractive surgery, it's, as you know, a well-established subspecialty among the ophthalmology, and is not like a minor, because it itself has grown a lot. We have incorporated with the years many new techniques, and not only we are famous because of laser vision correction, but not only we have laser, we have much more things. So the target is to remove completely or decrease at the less possible the necessity of wearing glasses. And as you know, as cataract specialists as well, cataract surgery has turned from just functional surgery, and today also has become more refractive surgery. Okay, so refractive surgery in these last 30 years has grown to get their own place in the portfolio of a normal eye hospital, and also has influenced other subspecialties to think and getting not only good visual results, but only to achieve the highest classes independence on the patients. This is true.
Absolutely. And one of the interesting questions that I often get asked by patients before I would send them over to your team is what age is appropriate to have laser vision correction at. So could you tell me a bit more about that?
Talking about laser vision correction, in theory, you can do at any age if the cornea meets the right conditions. Even we have done laser vision correction to people in the 70s or in the 80s for certain circumstances. But to achieve the best results, it's from when the people reach the 18, 20 years, where usually the myopia, the glasses are not growing, we can perform until 40, 45-year-old, when the presbyopia starts. Presbyopia, it's the necessity of reading glasses, and that makes not more difficult, but we have to aim for the correction of the glasses if we want to get the best results. But from, let's say, 18, 20-year-old until 40, 45 is the best period when the laser vision correction is let's say, the leader in the first choice, and gives the best results because the eye also functionally are the best.
That's right. And I think the key thing that you mentioned there is also kind of 18 onwards, because before then, if I understand correctly, the refraction or the measurements are not stable. Because this is also a question we often get asked for younger patients of ours, such as teenagers, who would want to get rid of glasses as quickly as possible. But it's important to be aware that you need to have stable refraction first, which, like you said, is getting to the age of 18 onwards.
Yes.
So that the results are as excellent as can be.
Yes, because patients want to get a long-term good result as well. So patients that wear glasses, they know that they have been developing the numbers, the diopters. Okay, these numbers that you see in the prescription of the glass are the result of the size and the shape of the eye. We as human beings, we grow since we are born until we become adults. there are so many changes in our bodies, our bones, our skin, our the structure of the body, the parts of the body, and that includes the eyes. Genetically, some people is developing different sizes and shapes of the eye, and that leads to, or many cases, to be well focused. And those are the people that don't wear glasses, but other people don't get a good focus in the eye because it's bigger, smaller, or maybe the shape, and this leads to take glasses. And usually, when you stop growing, when you become an adult, is when the refraction, the numbers, the diopters settle, and then we can aim. Because if we do the surgery and the patient is not properly settled, the new diopters that grow will appear again, because we change the shape of the eye, but we cannot stop the eye to change the shape or the size in the future.
That's it. And the other thing is very interesting is that, now we have all these different names for the laser vision correction. So often, not only patients, but for us as well, there's PRK, LASIK with an E, LASIK with an I. Now we hear about this thing called SMILE, and there's quite a range of treatment options available. So for our patients, how would you kind of demystify or make it simple to understand what these different things are? And how is it that you and your team would select one or the other for each patient? What determines which ones to go for?
The different laser procedures seems to be like a lot, but in just to explain briefly, there are two groups of laser correction procedures. One is the group where we, let's say, we polish or reshape the eyes from the surface. Okay, the surface laser procedures. This the classical is the PRK, that stands for photorefractive keratectomy, and basically it's a reshaping of the surface of the eye. They have been trying to do different variations of this technique. One is the Lasik with an E, or the more recently the trans PRK. But basically, all together are have the same design to reshape from the surface. But this has a advantage and a disadvantage. The advantage of this is that doesn't involve to create any cut in the eye, any layer. It's simply done on top of the eye. And the great disadvantage is that that involves as well to damage the surface epithelial layer. And that is what makes the post-operative slower. The final result is the same that any other laser technique, but that makes the post-operative a bit tougher for the patient. So we have to explain why we select this. Usually we select these surface lasers when, for instance, the cornea is thin, or in the analysis by the topography, the cornea shows any kind of possible structural weakness, let's say. No, they just to give you one example, if the cornea is thicker, it's supposed to be stronger than it's thinner. It's not so simple like this, but we select the patients this way. The other techniques that involves let's say, they are techniques that the recovery is faster. It's surprising how fast the patients start normal life. Next day, second day, they can go to the office. There is minimal inflammation. These techniques are, before it was the Lasik, in this case, Lasik is standing long time, and more recently, as you said, the SMILE. Both techniques, they have in common that we need to create some layers with cuts that, in this case, we advise not to perform with blades. We use a special laser for that, but that cuts, that layers, the intention is to preserve the epithelial layer. So we don't damage the epithelial layer on the other side that the superficial laser. And then it's the secret for the fast recovery. Of course, these techniques before were done with blades and cutting machines, mechanical machines. Today, not today, long time we have it, but the modern way, the safe way to do it is with these femtosecond lasers that create these layers with high precision. Then, when to advise one kind or the other, basically depends on this. if the cornea is strong, shows signs of strength, like symmetry, good thickness, good regularity, not too flat or too steep curvatures. There are so many factors that we have in our topographs. Then we can do this fast recovery techniques, the Lasik or Smile. If not, we can offer the surface laser. Some patients want some specific technique for maybe one relative did this technique or he was by that technique. In this case, we agree with the patient if the cornea is right for the procedure the patient want. Also, we have no preference because no matter what you do, the final result is the same. We haven't seen differences using one technique or the other regarding the results.
And that's a really good point you made, is that it's about putting safety first, in that the technique is decided based on what's the safest for each patient and what will give the best results. So which is why you have the kind of laser assessment appointments where all the tests are done to ensure that the cornea is correct for a certain technique. And that is what will determine the least side effects in the future and the highest chance of success. Now, one of the things that in your line of work crosses over with mine is to do with pressure inside the eye. So, of course, glaucoma is when you have high pressure in the eye, it's damaging the nerve. And from time to time, you will send patients to me who've come for a laser vision correction appointment, but incidentally, it's been picked up that the pressure is high. Now, the thing that we'd like to convey today is, why is that important? Why would someone with high pressure require treatment for the high pressure first before proceeding with the laser vision correction? And I think this is an important fact to convey. So could you share your thoughts on that?
In this case, you are more specialist than me, but yes, refractive surgery is an elective surgery. It provides quality of life. But the high ocular hypertension and then the glaucoma is a serious disease that can threaten the vision. And it's not frequent, but sometimes we find people that because they are usually young, glaucoma doesn't appear those ages, but sometimes we pick some patients that in the assessment, the pressure is higher than normal. Randomly, we found it, and it's lucky for the patient because first should be treated and should be assessed. It was considered glaucoma like a contraindication for classically for refractive surgery because the concept is only do refractive surgery to healthy eyes. But you know that if we get glaucoma in early stages, we can control the pressure, we can monitor the optic nerve, the visual field. It's a very early stage or not glaucoma existing at all, only ocular hypertension. Why not to do refractive surgery once we control this? Of course, refractive surgery, on the other side, if the patient has advanced glaucoma and wants to do multifocal lenses, it's clearly a contraindication because the result will not be good. So depending on the stage, I think it's a relative contraindication. But first of all, to treat the pressure, control the pressure, be assessed that you can get the stability of the pressure, and then later, if the patient considers that it still want to proceed for refractive surgery, then we can do the
exactly. And it goes back to that safety first principle.
Yes.
And also, I think it's also an important fact to convey that there can be certain steps of the laser vision correction process that can, such as docking, which can actually induce high pressure momentarily as well. So if your eye is already under stress from high pressure, it's just something that we'd like to avoid. So once, as you said, once it's completely stable, as safe as possible, and it's uncommon. So most people tend to have very normal pressures at the age groups in which you would have laser vision correction. And I would say that most people are able to go ahead with it and enjoy the benefits of it. So kind of moving along to kind of our older age group, which is past 45, as we discussed at the start, where you're starting to require reading glasses, something known as presbyopia. And people would want to get rid of their distance glasses, perhaps, or both distance and close glasses. And that's very important for quality of life. So what are our options at that stage? Of course, one option could be laser correction, but what could be the drawback of that? Because certainly from my side, most of these patients then go on to have cataract surgery once the cataracts start to develop. Because then, as you mentioned, we have these lens options available, which can correct distance and close vision for suitable eyes and can give quite good results as well.
No, when presbyopia comes into the equation, then you have to study the patient a lot, because not everybody we have the same lives. Not everybody we do the same activities. Some people is more outdoor oriented, some other is more indoor oriented. Also the jobs that we are doing. So we have to think how can I get this patient to use the glasses the less? If it's completely avoided, much better. But it's true sometimes, depending on the eyes, we can perform laser vision correction. But in laser vision correction, we used to do one kind of trick called monovision. Monovision, it's long time known, and it's basically to aim one of the eyes, the dominant, for the far, and the other we aim to have a closer range of vision. When the patient cannot focus in near distance, we make one eye by purpose to focus closer and let the brain to adjust the images. This is quite successful, but has some limitations, because what patients should be very aware is that the eye doesn't work the same before 40-45 than after 40-45. And that is why the interview is very important. When the laser vision correction with monovision maybe not accomplish the necessities of the patient, and still the glasses will be frequently used, is when we open the option of implanting intraocular lenses. We have diffractive multifocals, basically, and EDOF lenses. They are yielding very good results. They are never as good in terms of quality and coordination like the natural lens that we have before 40-45, but at the end what the patient wants is functionality, and it's true that they provide quite a lot functional near and intermediate vision, at the same time providing quite good far vision. So the range of the vision of those patients, it's restored according to the vision. There is some downsides of these procedures, should be discussed with the patient before, and the patient also should accept. General rule is that the more the patient is dependent on the glass, the more acceptance is from the vision of the lens. So we have also to wait until, one advice is that people that is using glasses for reading in a low frequency, maybe they are not the best candidates, because they still have their own functionality of the eye still is good. But for age, that functionality will be lost, and then they will rely on the glasses more and more. These are the ideal candidates, especially for the near vision, but also if they have far glasses, then the dependence is total, is complete. Then they can consult us and see if the case is feasible for multifocal lenses or laser vision correction with presbyopia.
Absolutely. And you touched on a few very key points there, which is basically, the technology is great, but it can't replace the beauty of the natural lens we're born with.
Exactly.
And so we want to preserve that for as long as possible.
Exactly.
And secondly, there's no one size fits all. So the beauty of also the technology now is that we can tailor and individualize the treatment options for each person's requirements. And I think this really is fantastic that we're able to offer this for our patients.
Today, I tell you, with the development of the last 30 years, we can tell that if the eye is healthy, we can aim anything. We need certain conditions of health in the eye, which the vast majority of the patients accomplish, but in terms of decrease the dependence on the glasses, we have enough range of ways, and also safe enough to provide what the patients want. That is why it's very important to meet the patient. It's very important the patient, we can know the patient also knows us, but it's very important for us to know the patient, because we need to know where we can serve the patient and provide the vision that the patient requires. And that is, patients don't have to think, oh, my case is too complicated, oh, my numbers are very high, or someone told me I cannot do. If the eye is healthy, we can reduce the dependence on the glasses in all the patients. This is the reality, unless the patient has any disease, or like an advanced glaucoma or any other problem. So this is for me the key message to the patients.
Absolutely. Well, thank you very much for the chat. I think that's all the time we have today for our podcast, Inside and Beyond, and we look forward to seeing you all on the next episode.
Thank you, Salman.